Hi, I'm Ken Harwood, and I first want to thank the Learning Health Systems Rehabilitation Research Network, or LeaRRn, inviting me to present this applied learning case. It's really an honor and a privilege to be able to share some of the work that I've been doing over the last 5 to 10 years. The title of my presentation is The Journey to Learning Health Systems, the Impact of Interoperability on Post-Acute Care. With the United States government's growing interest in standardized assessments in post-acute care and the increasing legislative and regulatory push having an interconnected and interoperable healthcare data system, the U.S. is getting closer to supporting learning health systems. This important work is essential to having clinically meaningful data sets that can lead to more informed and person-centered quality measures, and supporting a more robust, evidence-based, and fair payment system. An important stakeholder in these activities is the rehabilitation researcher who understands and can deal with complex health systems, is focused on learning and outcomes, and can address the challenges and opportunities associated with learning health systems. So toward this end, I'm very happy to make you aware of the important work the U.S. government is supporting to develop a standardized and interoperable healthcare system. This presentation will focus on our work in establishing this system and addresses the needs of a post-acute care. I will also apply some of the results of this work to my own research and recommend areas that we should explore further. So at the end of this presentation, what I hope for you will be able to understand and describe the U.S. government's journey toward data standardization and interoperability, and specifically why these things are so important. Demonstrate how the PACIO project aligns to the CMS goals, or Centers for Medicare and Medicaid goals, for standardization and interoperability. Following the presentation of a use case, analyze how the standardization of functional items can affect interoperability, and I think assess the potential impact of the PACIO project, well, really all this project, on rehabilitation practice, health policy research, as well as health services research. Over the past decades, many researchers and policymakers have discussed developing a U.S. healthcare system that is, at its foundation, a learning system, using real-time evidence-based information that is used to assist in better patient outcomes. During these discussions, the concept of learning health systems emerged. The definition of learning health systems was described and defined in many ways. In our work, we adopted the Agency for Healthcare Research and Quality's definition and description that a learning health system is a system in which internal data and experiences are systematically integrated with external evidence, and that knowledge is put into practice. As a result, patients get higher quality, safer, more efficient care, and healthcare delivery organizations become better places to work. For this concept to become a foundation of the U.S. healthcare system, data would need to be collected on a national level, integrated with experience and evidence-based information, and shared with important stakeholders in real time, and in a manner that is understandable to achieve the desired outcomes. Certainly, a great deal of technical work would need to be done before we see this system realized. But in addition, patients, clinicians, administrators, payers, and most importantly to this discussion, researchers would all require additional training and understanding of the system, how to use the system, and how to best determine desirable and useful outcomes. And this is why I need to say that organizations like LeaRRn is so important for us to maintain or achieve the idea of learning health systems, because we all believe that more information is necessary, even for those people who are somewhat informed on learning health systems. In our work, we were concerned that although these strategies are important to provide the infrastructure for learning health systems, we thought a better understanding of the competencies needed for fully functioning learning health systems needed to be explored. Through a scoping review, we reviewed the extant literature to identify and describe the requisite individual competencies or knowledge, skills, and attitudes, and system competencies, that is the capacities, the characteristics, and capabilities to develop and implement a functioning learning health system. We identified these patient, health system worker, and system competencies. And I apologize for the kind of the small font that I had to use, but I really wanted to focus really in that center bar, which is health system worker, and that last bullet, which is really this idea of the embedded researcher in a learning health system. This is the person who is able to partner with diverse system stakeholders in all phases of the research process. They apply research methods that may not be the standardized methods that we all learn through our doctoral or graduate work, and also be very concerned about the standards and ethics to learning health systems related problems. Actually, a very large issue that they're dealing in Europe right now with. Knowledge of system science, informatics, improvement, and implementation science. So we really do, or I really feel that the role of the rehabilitation researcher is extremely important for the really implementation of a good learning health system. The federal government, through the Office of the National Coordinator, has established a vision, mission, and strategic goals for the development of information technology in healthcare. So basically, this forms the foundation of what's going to be developed over the course of our really IT evolution. The ONC envisions a health system that uses information to engage individuals, lowers costs, deliver high-quality care, and improve individual and population health. The mission is to improve the health and well-being of individuals and communities through the use of technology and health information that is accessible when and where it matters most, which is at the clinic and within the person's own computer, if you will. In addition, the ONC has established a strategic mission and goal, strategic goals that really is to address or achieve the vision and mission. And although I won't go through all the objectives and the specific goals, as you can see, the goal here is to establish a system that is inherent within our electronic health records, if you will, a system that is secure, a system that actually allows us to connect all the information from one setting to another and provide it to the patient and be easily accessible, although certainly secure and privacy issues are there. Again, for this discussion, what I think is important is you'll see that the researcher is extremely important to actually allow us not only to understand the system, but to analyze it. And I think this is something you're going to hear this thread throughout the whole presentation is the real important role of especially the rehabilitation researcher in all this process. So the National Legislative Roadmap has been decades in the making. And there are some highlights that I'd like to point out that really show that this is not only just words through some federal agencies, but certainly Congress and also the executive branch of the government is extremely committed to. So let's just look at some of the highlights in the legislative roadmap toward interoperability and standardization, which actually are interconnected. And you'll see why as we go on. The Benefits Improvement and Protection Act of 2000, or BIPA, required a report to Congress on standardized patient and resident assessment used across Medicare post-acute care services so that common data elements can be comparable. This was really the start of the road towards standardization. Before we make anything interoperable, we have to standardize our language and what we're actually using to a technical use as we move forward in the interoperable road. The 2005 Deficit Reduction Act mandated CMS to test the reliability and the validity of these developed standardized patient assessment data elements and the development and implementation of PAC payment reform, which is always going to be hand in hand. So making sure that we actually not only have data, standardized data elements, but also a payment system that's based on those data elements. And really, if you will, the improvement or decrement, if you will, of those outcome data elements. You may recall during this time, the CARE tool was developed. And this also was really the first patient assessment, standardized assessment instrument that was directed toward collecting patient data, especially in post-acute care, but also in acute care situations. This actually was really developed through a lot of work and through really the associations like APTA, AOTA, ASHA, all got involved in this discussion of developing and kind of putting their opinions about the CARE tool. But finally, in 2014, the Improving Medicare Post-Acute Care Transformation Act, or IMPACT, mandated the submission of the standardized clinical assessment data for Medicare beneficiaries. The Act also required PAC assessments to be modified to include standardized patient assessment data and the submission of that data in health information exchange and facilitated coordinated care and improved beneficiary outcomes. So really at this point, after the standard data elements were developed, then they started to look at what was the needs of all the different PAC settings, the skilled nursing facilities, home health cares, long-term care, and then finally the work that we did on home and community-based services. So making sure each of those areas have standardized assessments that they can actually look at comparisons among the different settings as well as within the settings. So this slide kind of shows that issue. So really when we start looking at those things like let's look at the minimum data set, which is for skilled nursing facilities. You can see that the circle includes items or data elements that would actually be very specific needs for the skilled nursing facility. But you'll see all these circles have an intersection among them. These are what we call the uniform data elements, or the GG items, which you may be familiar with, which basically mandate using the same language, the same definition, and the same response set. So now as we go around the circle, we can see that the IRF-PI for inpatient rehab facilities, which is their standardized assessment, LCDS, which is for long-term care hospitals, we already talked about SNFs, and the OASIS, which is for home care agencies, basically have these standardized elements. The FASI, which is for home and community-based services, is something we developed at George Washington University in coordination with IBM Watson and now the LeaRRning group, is actually now a standardized assessment data element tool that actually can be used to determine needs for individuals with home and community-based services. So why standardization? And I think that's really been a big topic of conversation with rehabilitation. It's basically there's so much discussion about, well, we need these specific, very detailed items that show what our patient needs. But in reality, we also need to make sure that we have some standardization that allows us to do a number of things. First of all, data standardization in PAC is important for comparing the impact across Medicare and Medicaid programs. If you're not comparing the same thing, we all know that you're not going to be able to make great conclusions. Questions like what settings are better aligned with patient-centered outcomes are not only rely on course data is extremely important. Having standardized data collection in PAC settings allows harmonized data capture and exchange, lessens variation, and increases clear communication. Patient-centered care can be better coordinated and supported, especially when information is shared among all settings in real time, which is what we're going to be talking about today. Then once the information is collected from all the settings, quality comparison is enabled and becomes part of the workflow. So basically, we can compare things like how has function changed as a person leaves an acute care hospital into a SNF, into a long care, as well as compare and functional items within each of the different SNFs, long-term care hospitals, IRFs, et cetera. So really what we're looking at is this standardization supports the CMS goal of a patient-centric, quality-controlled, unified PAC system. Obviously, this will also become part of a payment system. So when we start looking at the items, which I don't think we realized for a fairly long time, if you looked at the data elements in each of the settings, like with the FHIR, the MDS, the OASIS, we actually found that there were significant differences in the definitions of something as simple as eating. So, for example, in inpatient rehab settings, the FHIR eating item considers the use of utensils and swallowing food, while the MDS eating item used in skilled nursing facilities considered alternative means of nutrition, such as tube feeding and IV fluids. This is problematic because, as we can imagine, as you start exchanging data, you expect the same definitions to be used. And in fact, poor conclusions can be made when we start aggregating that data. So now, after this standardization, which actually has been going on for a number of years now, we actually have standardized items with the same definition and response set in all the standardized CMS outcomes, including the newest one, which is the FASI. Okay, so now we talked about standardization and really the importance of standardization to interoperability. Let's talk a little bit more about interoperability. Why is it important? What are the benefits? So at this point, we know when things are interoperable, and this, what I mean is the ability, as you look at the graphic here, that information follows the person as they move from any setting. We obviously can start looking at reduced health worker burden and burnout caused by duplicative data entry and lack of needed information siloed in other systems. So we'll no longer have really the communication between an acute care hospital and, let's just say in this scenario, post-acute system A or C, I should say. Basically, that information would be exchanged and improved. And actually, the U.S. Surgeon General's health worker burnout report cited that methods to optimize administrative paperwork and increase care coordination have the potential to decrease health worker burnout. In addition, to benefits, improve patient outcomes by reducing the duplicative tests already completed at other settings, and reduces errors caused by incomplete, old, or lack of important patient information. In fact, when it really comes down to it, we will no longer need to rely on the patient or family memory for accurate data. The data will be moved from one setting to another. Obviously, this is going to lower costs to the healthcare organization, obviously also not only with healthcare worker burnout, but also hopefully with increased patient outcomes. And then freely exchanging health information not only supports optimal outcomes for the patient, it also allows us to collect and share objective information about the role and value of what we do as healthcare providers. So what I believe is this really is the framework to a comprehensive data set for not only for understanding the analytics of systems, but also provides us as researchers great data sets with also finally functional level data. When a person transitions, which we already know, between healthcare settings, their care is often fragmented and can lead to poor health outcomes, increased burden, and increased costs. Interoperable health information exchange has the potential to improve patient and provider communication and support access to longitudinal health information. CMS and the Health Federally Funded Research and Development Center, operated by MITRE, co-founded the PACIO project to help improve interoperable health information exchange with a focus on post-acute care information. The PACIO project is a consensus-based collaborative effort, including policymakers, standard organizations, providers, and industry to advance interoperable post-acute care health data exchange between healthcare settings, providers, patients, and other key stakeholders. The primary goal of PACIO is to establish a framework for the development of fast healthcare interoperable resources, or FHIR, technical implementation guides and referent implementation. So basically, the English version of that is, with the PACIO project, using FHIR, which is an internationally accepted code system, and specifically that allows for the transfer of codes to be not only out in the field, but also free to any provider or vendor, allows us really an ease to transfer and interchange this information that really has a team of both based on the technical ends, that is the, if you will, the EMR vendor technical leads, as well as the clinical entities, which actually is the providers as well as the patients. So it's really an exciting venture. PACIO has a number of work groups and activities. I won't go through them all now, but I think for us as rehabilitation individuals, the physical functioning and engagement is a particularly important work group that many physical therapists, occupational therapists, speech language pathology professionals, and others have actually been engaged in. In addition, the PACIO physical functioning engagement, which I'll just run through the next one, actually has established the World Health Organization's International Classification of Functioning and Disability, or ICF, as a framework on the basis of the coding. So therefore, when it really comes down to it, with the PACIO project, personal function engagement, we will then basically be able to kind of, if you will, reference the ICF code system, which actually is a really very robust and highly well-organized classification system that actually allows us really I think the flexibility in the future to expand it even further. But that's, I think, another discussion. So what actually does this, what is the product of these work groups? Basically, what happens is after these discussions with vendors and with IT professionals, as well as the clinical professionals, we basically help develop something called an implementation guide. This is the technical specifications that allows the vendors to actually take what we think is important information, use standardized codes and systems and structures that allows them to actually then put it in their system for free, because it's actually, these are all open, as well as provide a use case. And that actually, I'm sorry, I went through that quickly. This is an example of what the PFE implementation guide looks like. And again, I give you the references at the end if you want to go take a look at very specific information. But in addition, we developed something called a use case, which actually is really, can we see an individual who has certain rehabilitation needs and goes into post-acute care? Can we actually not only describe the technical things that are necessary, can we describe the person and the individual providers that they see through the system? So although this is a fairly flat screen, what we're really seeing is an individual who was receiving a home and community-based services or long-term systems and support. So there's care that they had a need. This individual fell, went into hospital after, then actually had a stroke. And then basically we see this individual go through the post-acute care setting and with different problems, and as well as different challenges that had occurred to this Betsy Johnson. And what's really interesting is, in addition, we're actually matching that up to the electronic health data exchange. And we basically do this through something called a connect-a-thon. So what we're going to do is, what I'm trying to do now is set up about for a film that we'll be taking a look at, which actually is a film from the PACIO group showing something called the connect-a-thon result. And so before we begin with the film, let's have some concepts or understand some concepts that actually are important to understanding as you kind of look at this fairly quick film. And actually there's a lot of stuff, and I'll try to give you some guidance. First of all, the DEL. The DEL is a data element library, which is a centralized resource for CMS assessment instrument data elements. Basically what it is a library of questions and responses, like walking. How does a person walk? It defines it, and then it gives the appropriate responses. So basically, not only does it give the definition, but it also gives the health information technology standards associated with that. Very important thing, and actually CMS is the house, really the owner of this data element library. A connect-a-thon, and that's actually what we're going to see the results of, is an event that is centered on developing the HL7 FHIR specifications. And again, all that is basically these internationally accepted technical specifications that have to be accepted and have to be approved by HL7 to make sure that they are actually within standards. So they include things like resources, profiles, and implementation guides. And we're going to focus on the implementation guide. The purpose of a connect-a-thon is to prove that the specification is complete and facilitates FHIR implementation guide maturity. So basically what really happens is a group of individuals, clinicians, vendors, technical individuals, informaticists come together, usually in real time at a certain place, but sometimes virtually, and they actually test it out. They use that Betsy use case and they try to exchange data from novel users, and that's actually what goes on there. And then finally, a health data manager, which is a system to validate, organize, protect, maintain, and process the health data. So basically, this information gives you some idea of some of the language that goes on. Before I start the film, what I would like also to do is give you some framework on the PACIO film we're going to see. I'm only going to do a clip. I highly recommend going to YouTube and at the reference that I gave you to look at the whole film. But really what it's doing is showing how this data is exchanged. So you're going to see a lot of information be exchanged at the time. On the left-hand side of the screen, there'll be a lot of it's almost like the EMR. So people inputting data. On the right-hand side of the screen, you'll see actually part of the Betsy use case that's actually being exchanged. And on occasion, you're going to see coding that's below that screen is actually the transfer of data. This was done in real time. This is actually testing if it worked. And I should tell you right now, ruining the end, it worked. So at this point, we are able to actually exchange this type of information using the codes very successfully. And that's why actually the implementation guide, at least the first one for the personal functioning engagement has been published by HL7. So now we're going to switch screens and we're going to go to a film that actually shows you how that data exchange. Again, I'm starting in somewhat at the middle of this, and I'm going to assume you see this. If I hear differently, I'll make sure I switch back, and let's begin the film.
The PACIO project was created in February 2019 to help address these issues and includes a great experienced community of several dozen participants, including vendors, government agencies, clinical consortiums, clinicians, and contractors. These participants bring many different perspectives and skills to the table, and PACIO would not be able to develop these standards without them. The PACIO project works on several different use cases. We work on functional status, cognitive status, and SPLASH, which is speech, language, swallowing, cognitive communication, and hearing. Those are all included and packaged together under a FHIR implementation guide called Personal Functioning and Engagement. In addition, we are working on developing FHIR exchange standards for advanced directives and reassessment time points. Reassessment time points break long-term encounters into smaller chunks. Long-term encounters can last several months or even years, and reassessment time points help to further organize that information. Finally, we take a lot of this data and apply them to quality measures, and we actively work with other groups to see if they can calculate quality measures from our data. I would like to introduce you to Ms. Betsy Smith-Johnson, a fictional patient who demonstrates how gaps in health information, lack of standards, and miscommunication can be solved. Her story illustrates how individuals and caregivers can be active participants in their healthcare by ensuring the right information is available when and where it is needed. Our 5-scene scenario begins in scene 1 with Betsy at home, where her care plan is created and entered by her care coordinator using software from FEI systems to capture her goals, like dancing at her son's upcoming wedding, transportation needs, and what other information she might need. That care plan is sent to Patient-Centric Solutions Health Data Manager, a central repository for Betsy's health information that can later be accessed through Alterum software or by Betsy herself using Patient-Centric Solutions Patient Share application. Betsy's advanced directive information is also captured and stored using AD Vault software, such as her living will, which can be retrieved later by other facilities, as well as Betsy, through the MaxMD mobile application on her phone. Patient-Centric Solutions Health Data Manager also pulls in data from the Michigan Health Information Network so that information about Betsy's demographics, conditions, medications, lab results, and immunizations are available. In Scene 2, Betsy falls after suffering a stroke and goes to the hospital. The hospital is able to access her care plan and advanced directive information through their EHR software, so they are informed about Betsy's history. The hospital uses a PAC assessment application that retrieves standardized assessments from the CMS data element library, populates the form for that assessment, and collects the information from the clinician. That data is then sent to the EHR system and the health data manager. Thankfully, Betsy's condition improves in Scene 3, and she is discharged to a skilled nursing facility. The skilled nursing facility can retrieve the assessments done at the hospital, including her care plan and advanced directives, and perform new assessments, which are sent to the health data manager and CMS. Betsy continues to improve and is discharged back home under home health agency care, which is also able to pull up, using Patient-Centric Solutions software, all of the assessments done at the hospital and at the skilled nursing facility, her health care plan, and advanced directives so they can provide her the best care. The skilled nursing facility performs additional assessments and fills out the necessary forms using the Matrix Care EHR software, which retrieves the assessment from the CMS data element library and displays the form for the clinician to complete. Once complete, it sends the assessment to the health data manager and CMS for collection and analysis. All along the way, in Scene 5, Betsy and her caregivers can use the Patient Share application from Patient-Centric Solutions to access all of the information collected, including conditions, care plan, medications, assessments, and her progress. Betsy can also provide consent to her son, Charles Johnson, who can log in separately through ID.me identity management software to access his mother's information and monitor her progress. This demonstration shows how multiple information sources can be integrated together across 16 systems in real time to provide patient-centered care, not provider or system-centered care. It provides an up-to-the-minute, fully informed, patient-centered personalized care plan to bring together the individual patient, their caregivers, and the care team. Information can be gathered more completely and shared to provide responses quickly at the point of care. The patient is more engaged and can see and validate their own data. A feedback loop can also be built for continuous improvement, where performance can be measured, analyzed, drive clinical research, which can inform new healthcare policy and clinical decision support, improving delivery of care not only at the facility level, but most importantly, at the patient level.
So hopefully you could see, I know it's somewhat confusing, but hopefully you're seeing right now, first of all, my slides. And then second of all, is that you kind of see that the issue of interoperability and standardization is not only an idea now, it certainly is in fact reality. So that's kind of just showing that. So I'm going to assume you are seeing my slides. And now I would like to talk a little bit more about really the potential that we have as researchers. What I'm showing now is a slide of a result of the study that I did a while ago, or myself and my team, our team did, where actually we were looking at low back pain and seeing if in fact the first person who saw an individual with low back pain what their outcomes were like. And obviously, what was available for us was claims data, and we were interested in individuals 18 to 65. So it wasn't Medicare, we were looking at private health insurance. So we looked at about 4 million claims, and we actually started to, what our interest was if in fact a person started, let's just say, with a physical therapist or a chiropractor, what was the whole trajectory of their low back pain episode? And we followed them from the index date, which is the first time they were diagnosed with or were seen for low back pain, to a year out. And we calculated things like outcomes like cost, total cost, the use of opioids, which actually was a significant finding for us, x-rays, et cetera. And that alluded to well-provided care, or clinical practice guideline care. So what I'm showing now is one of those slides from the study, which actually showed both total, adjusted, total, and out-of-pocket costs dependent upon the first provider seen. So what we can see is obviously, and I don't think a surprise to any of us, is that there is a variation of cost, both total and out-of-pocket cost, depending upon the provider. That is, again, the first provider seen. And what we also saw, I think as a physical therapist myself, I was particularly interested in this difference, which was basically the difference between a physical therapist and a chiropractor. And what we certainly saw, and again, this is not new, there are other studies that did show that chiropractic care does tend to be less than physical therapy type care for many reasons. And in their outcomes, we also saw that emergency room visits were higher for chiropractors than for PT, which needs to be explored. But basically, what we were limited to in claims-based data was these ideas of these cost and utilization measures. What we didn't know is there a difference between the PT and the chiropractor in functional measures? Was one more functional? Was one more out doing the life that they want to live? Were they able to walk, etc.? So if in fact PACIO or this whole interoperable system is realized, we will have then at least the beginning of functional level data. And again, we'll probably start with data like the GG items, like that are self-care mobility. And if you're not familiar with the GG items, very easy, just go onto the web and actually look up Medicare GG items, and you'll see the wealth, or you can go to the data element library. But really, it's on the GG items are self-care, mobility, and IADL types of issues. More information, certainly. Is it exactly the information we would want for low back pain? Not necessarily. And that's why I think it's so important for the researchers also be part of this conversation. We really do need to look at an expansive code set that can be standardized, that doesn't only look at these measures like the GG items, but also may, in fact, using the ICF, for example, as a code system, looks at things like activities and participation in life. So again, that's why I'm employing all of us to really think about this discussion and try to move us all forward in working on interoperability, because it is coming. So in conclusion, I think it's clear to say that the US government has extended significant support to the developing a health information system that is interoperable, shareable, and again, based on standardization. And it is exciting for me that I would say that this is a foundation to the development of learning health systems. Progress has been made in achieving these goals, and especially in post-acute care through the PACIO project. Again, I invite you to look at the whole film because it really does show the whole trajectory of the whole PACIO project. Significant impact on rehabilitation practice and research, as you can imagine, not only for practitioners to have information of the setting that an individual just discharged from, which actually isn't possible right now in most cases, because each one has their different EHR vendor, which doesn't communicate. Having this ability to communicate amongst different settings is powerful. But I think as a researcher also, the idea of having a truly complete data set is really exciting. And then I think, again, last time I'll say it, but I do think continued participation is needed by multiple stakeholders. I would certainly say APTA, AOTA, as well as ASHA is involved in these discussions, but I would hope that we would see much more provider, researcher involvement in this. So thank you so much for allowing me the time to talk about not only the work that's going on, but also the potential of moving forward. I would imagine we will be seeing much more legislation in this area. I'm just hopeful that we will all be part of this. Thank you very much.